Hi, and welcome to Medaculus. Today's topic is bacterial vaginosis. Bacterial vaginosis is a dysbiosis of the vagina, characterized by an overgrowth of predominantly anaerobic organisms, such as Gardnerella vaginalis, Prevotella species, Mycoplasma hominis, and Mobiluncus species, and a loss of lactobacilli. The vagina loses its normal acidity, and vaginal pH increases to greater than 4.5. BV is not generally regarded as a sexually transmitted infection. However, the prevalence is higher amongst sexually active women than non-sexually active women, and it is considered by some experts to be sexually associated. Causes. The exact etiology and trigger for bacterial vaginosis, BV, is unknown, but symptoms are thought to appear when the vaginal pH raises following the loss of lactobacilli. There is no specific etiological agent, and so rather than being considered as a sexually transmitted infection, STI, it is often termed a dysbiosis, a change to the usual balance in the vaginal microbiome. Factors that increase the risk of developing BV include being sexually active. BV is not considered an STI, but being sexually active or having concurrent STIs increases the risk of developing BV. It is much less common in women who have never been sexually active. Having multiple male sexual partners, female partners, sexual relationships with more than one person, recent change in sexual partner. Certain sexual behaviors may increase risk, such as anal and oral intercourse followed by vaginal penetration, and in women who have sex with women, receptive oral sex, and the use and sharing of unwashed sex toys. Not using condoms and menstruation. Semen and menstruation are linked to alkaline vaginal pH. Douching. Seropositivity for herpes simplex virus 2. Presence of a copper intrauterine contraceptive device. Cigarette smoking. Genital hygiene. Not washing vaginal region. Infrequent change of underwear. Ethnicity. BV is more prevalent in Black women, 45 to 55%, than in Caucasian women, 5 to 15%. Factors which reduce the risk of developing BV include circumcised partner, consistent condom use, hormonal contraception may be protective. A systematic review and meta-analysis found that combined hormonal contraception and progesterone-only contraception are associated with a reduction in the prevalence and incidence of BV. Complications and prognosis. Women with bacterial vaginosis, BV, are at increased risk of acquiring sexually transmitted infections, STIs. Women with BV have a twofold increased risk of acquiring HIV compared with women without BV, and HIV-positive women with BV have a threefold risk of transmitting HIV. Women with BV also have a 1.5 to 2-fold risk of acquiring chlamydia and gonorrhea, a 9-fold risk of trichomoniasis, and a 2-fold risk of herpes simplex virus, HSV, type 2 compared with women without BV. A prospective study of women with clinically suspected pelvic inflammatory disease, PID, reported a significant association between the presence of BV-associated bacteria and the presence of endometritis and recurrent PID. There may be a link between acquiring human papillomavirus, HPV, and the development of cervical cancer. BV is also associated with several obstetric and gynecologic complications, including late miscarriage, preterm labor and delivery, preterm premature rupture of membranes, spontaneous abortion, low birth weight baby, postpartum endometritis, post-cesarean delivery wound infections, post-surgical infections, subclinical PID. Recurrence of BV is common. Reported recurrence rates are variable, but may be up to 23% at 1 month after treatment, up to 43% at 3 months, and up to 58% at 12 months, with one study reporting recurrence rates up to 80% within 9 months. This seems to reflect a failure of the normal lactobacilli to re-establish dominance and a re-emergence of the bacteria associated with BV. Diagnosis. Take a history. Ask about the symptoms experienced. Approximately 50% of women with bacterial vaginosis are asymptomatic. When symptoms are present, BV is characterized by a fishy-smelling, thin, gray/white homogeneous discharge that is not associated with itching or soreness. Check for associated symptoms which might indicate the presence of other pathology, such as dysuria, genital skin problems, abnormal vaginal bleeding, dyspareunia, and abdominal pain. Also ask about the duration and severity of symptoms and any exacerbating factors, such as after intercourse or during the menstrual cycle. Any treatments tried, prescription or over-the-counter, and their effects. The presence of contributing factors, including smoking history, the use of vaginal products such as douches, deodorant, and vaginal washes, and the use of antiseptics, bubble baths, or shampoos in the bath. Medical history, past and present. Medication history, including the use of oral or intrauterine contraceptives. Possibility of pregnancy. Possibility of a foreign body, retained tampon, any other items inserted into the vagina. Take a sexual history. Ask whether they are sexually active, the gender of their partner, whether they are in a committed or casual relationship, the time interval since previous sexual partner, and about the use of condoms. Ask about symptoms or risk factors for blood-borne viruses in the partners, such as known or suspected STIs, or injecting drug use. Assess the woman's risk of STI. Anyone who has condomless sex with new or casual partners is at risk of STI, particularly those who have frequent changes of sexual partners. Women are considered at increased risk of an STI if they are younger than 25 years of age or have had a new sexual partner or more than one sexual partner in the last 12 months or have had a previous STI. Signs. Using a speculum, take a swab of the discharge from the lateral wall of the vagina. Test the pH of the discharge. Ideally, pH of the discharge should be ascertained at the time of the examination in order to make the diagnosis of bacterial vaginosis and to help distinguish between BV and other causes of discharge. After introducing a speculum, roll a swab anywhere on the vaginal wall to obtain a sample of the discharge. Avoid the cervix, which has alkaline secretions, and also avoid the posterior fornix where cervical secretions can collect. Rub the discharge from the swab onto narrow-range pH paper, pH 3.8 to 5.5. Urine pH dipsticks are not suitable. Measure the pH by comparing the color of the moist test section of pH paper against the graded standard. The normal vaginal pH in a woman of childbearing age is 3.5 to 4.5. A pH greater than 4.5 is suggestive of, but is not specific to, the diagnosis of BV. Raised vaginal pH can also indicate other conditions, such as trichomoniasis. If the diagnosis cannot be made from history, examination, and pH, send a sample of the discharge to the laboratory for gram staining and microscopy. If symptoms are typical, there is no itch or soreness, and vaginal pH is greater than 4.5, there is no need for a swab for microscopy and/or culture. If testing for pH cannot be done at the time of examination, or if there is diagnostic doubt, then the discharge can be sent to the lab for microscopy, which is the test of choice for BV. If not known, speak to the local lab about the preferred method to send the sample for gram staining. Ideally, the sample of discharge is smeared onto a slide and sent in a slide box, but some labs will prepare the slide themselves from the swab. Place swabs in Amy's transport medium with charcoal. Transport samples to the laboratory as soon as possible. If there is a delay in transportation, swabs should be refrigerated at 4 degrees Celsius for no longer than 48 hours. Give information on the accompanying form about the history and tests required, gram staining and microscopy for BV and/or culture for other causes if there is recurrence or diagnostic doubt. A high vaginal swab, HVS, for culture is not routinely required for suspected BV unless there is suspicion of upper genital tract infection, or if the woman is pregnant, postnatal, or has had recent gynecological procedures. If an HVS is sent to the lab, give full information about the site sampled, the symptoms and history, and the infection suspected so that the relevant tests can be done. If the woman declines a speculum examination, a self-taken low vaginal swab of the discharge may be used for pH and microscopy. If the woman is at high risk of an STI, either refer to a genitourinary medicine clinic or test for the following. Chlamydia using a vulvovaginal swab. Insert a dry swab about 2 to 3 inches into the vagina and gently rotate for 10 to 30 seconds. Gonorrhea, using a vulvovaginal swab as above. Trichomoniasis, using a swab taken from the posterior fornix at the time of the speculum examination. Offer blood tests for HIV and syphilis. Offer chlamydia screening to all sexually active people younger than 25 years of age annually or earlier if they have changed sexual partners. Differential diagnoses of bacterial vaginosis include other infections such as candidiasis, characterized by a white, odorless, curdy discharge that may be associated with vulval itching and superficial soreness. Trichomoniasis, characterized by a fishy-smelling, yellow/green frothy discharge that may be associated with itching, soreness, and dysuria. Chlamydia, often asymptomatic but can cause purulent or mucopurulent vaginal discharge and dysuria and does not usually present with itch. pH of the discharge is 4.5 or less. Gonorrhea rarely presents with itch and is associated with pain and a purulent cervical discharge. Genital herpes may present with redness, itch, and ulceration. Discharge is uncommon, and acute vulval pain is often the defining symptom. Sometimes a watery vaginal discharge may appear 7 to 11 days after primary infection. Mixed infection. It is possible for two or more infections to coexist, such as BV together with candidiasis or trichomoniasis. Up to 10% of infections are mixed. Non-infective conditions, such as normal physiological discharge. There should be no irritation, itch, or pain, and it should not be profuse. Physiological discharge may increase suddenly in menarchal girls, varies throughout the menstrual cycle, and often occurs during pregnancy. Malignancies. Malignancies of the vulva, vagina, cervix, or uterine lining are rare but serious causes of vaginal discharge. Cervical ectopy or polyps. Fistulae. Atrophic vaginitis may cause vaginal discharge in postmenopausal women. Foreign body, such as tampon, may result in vaginal discharge. Allergy, for example, to chemicals or latex. Mechanical irritation, for example, due to lack of lubrication. Management of suspected bacterial vaginosis in women who are not pregnant. If the woman is asymptomatic, treatment is not usually required, other than in the context of having some gynecological procedures. If the woman is symptomatic, advise that, where possible, she should reduce exposure to contributing factors, such as smoking, vaginal douching, and the use of antiseptics, bubble baths, or shampoos in the bath. Prescribe oral metronidazole 400 milligrams twice a day for 5 to 7 days. If adherence to treatment is an issue, a single oral dose of 2G may be used if appropriate. If the woman prefers topical treatment or cannot tolerate oral metronidazole, prescribe intravaginal metronidazole gel 0.75% once a day for 5 days. Off-label for women aged younger than 18 years, or intravaginal clindamycin cream 2% once a day for 7 days. Oral clindamycin and oral tinidazole are alternatives, but are less preferred. A test of cure is not required if symptoms resolve. If symptoms persist, check that the initial treatment was adhered to. Reconsider the diagnosis. Perform a speculum examination and take swabs of the discharge for pH, microscopy, and culture. Inquire about continued exposure to contributing factors such as smoking, vaginal douching, and the use of antiseptics, bubble baths, or shampoos in the bath. For persistent bacterial vaginosis in women with an intrauterine contraceptive device, consider removing the device and advising the use of an alternative form of contraception. Ensure that the current episode is adequately managed. Prescribe an alternative treatment. For example, if a single 2G dose of metronidazole or an intravaginal preparation was used previously, prescribe oral metronidazole 400 milligrams twice a day for 7 days. In the unlikely event that a woman with confirmed BV has not responded to a 7-day course of oral metronidazole, consider discussing with a gynecologist or genitourinary medicine (GUM) specialist regarding further treatment. Routine screening and treatment of male partners is not indicated, but consider testing and treating the female partner in a same-sex relationship. If symptoms recur, advise the woman that recurrence of symptoms is common. Reconsider the diagnosis. Perform a speculum examination and take swabs for pH, microscopy, and culture. Further examination and investigations may not be necessary if a previous episode of recognizably similar symptoms was previously diagnosed to be BV and symptoms and signs cleared after antibiotic treatment. Symptoms, signs, and microbiological evidence from swabs of other conditions causing vaginal discharge were absent. Characteristic symptoms and signs of BV were present. Inquire about continued exposure to contributing factors. Treat the current episode with a 7-day course of oral metronidazole 400 milligrams twice a day. Routine screening and treatment of male partners is not indicated, but consider testing and treating the female partner in a same-sex relationship. If the diagnosis is confirmed and symptoms recur frequently despite adequate management in primary care, and symptoms are adversely affecting the woman, consider prescribing metronidazole vaginal gel as suppressive treatment, off-label use, if experienced in treating recurrent BV in primary care. Otherwise, discuss management with a gynecologist or GYN specialist. Management of suspected bacterial vaginosis in women who are pregnant. Do not offer pregnant women routine screening for bacterial vaginosis, unless they are going to have a termination of pregnancy. However, if a pregnant woman is incidentally found to have BV, manage as follows. If the woman is asymptomatic, discuss with the woman's obstetrician whether treatment is appropriate. If the woman is symptomatic, advise that, where possible, she should reduce exposure to contributing factors such as smoking, vaginal douching, and the use of antiseptics, bubble baths, or shampoos in the bath. Prescribe oral metronidazole 400 milligrams twice a day for 5 to 7 days. High-dose regimens, single oral dose of 2G, are not recommended during pregnancy. If the woman prefers topical treatment or cannot tolerate oral metronidazole, prescribe intravaginal metronidazole gel 0.75% once a day for 5 days. Off-label for women aged younger than 18 years, or intravaginal clindamycin cream 2% once a day for 7 days. Second or third trimester only for clindamycin. Oral clindamycin in the second and third trimesters is an alternative but is less preferred. Repeat testing after 1 month and offer further treatment if the woman is still symptomatic or if treatment has been prescribed to reduce the risk of preterm birth.